Hi, I'm very excited to be part of the Remind initiative. The reason for that is the challenge we're facing in the modern world in terms of demographic shift. The challenge is accelerated by the fact that the number of people living with chronic disease is increasing dramatically. With that increase comes higher resource utilization and human suffering, which also afflicts relatives and other caregivers. A large portion of the elderly are living with dementia and what comes with that disease. Dementia is also one of the few increasing causes of death in our part of the world, in contrast to major diseases like cardiovascular disease and many types of cancer. We need to address this challenge together by working closely in the intersection between different skills and knowledge domains, which is also very rewarding since you learn from each other. It's also important to figure out how innovations, new ideas and thoughts will fit into the ecosystem of care surrounding each individual with dementia. We will not be successful if we don't understand the environment of the patient. In Remind, we will try to merge all these skills, knowledges, and knowledge domains, including computer science, medicine, and social science, in order to achieve that success. I'm really looking forward to the 2 years ahead of us where new knowledge will be created and new networks will be built. Thank you.
So welcome to the Halmstad Intelligent Home. So the Halmstad Intelligent Home is a fully functional apartment located at the same building as the School of Information Technology at Halmstad University. The Halmstad Intelligent Home is funded by the Center for Applied Intelligent System Research. This apartment is used as a platform for research, development and experimentation in the domain of smart environments. The smart home is the most common example of a smart environment. A smart home uses home-based network-enabled device to monitor the residents. Collected data is used to learn the habits and preferences of the occupants so the home can take actions autonomously. Differently from home automation, the smart home is not configured with predefined rules. The idea is that a smart home learns the behavior and the routines of the resident to take these autonomous actions. There are different types of sensors used in smart homes. We use motion sensors, temperature sensors, light sensors, occupancy sensors, weight sensors, and all these are used to implement different functionalities. These functionalities are normally associated with increasing comfort, increasing security, and energy management. These mostly are used to reduce costs. Over the past 10 years, there is an increased interest in using smart home technologies in healthcare. The main motivation for this is that the demand for healthcare is increasing. However, the amount of available healthcare resources is not increasing in the same rate. So smart home technologies provide an opportunity for monitoring the function of the individual to monitor and assisting well-being, as well as to provide cognitive assistance. Smart home then do not only provide an opportunity for complementing healthcare, but also to enable concepts such as healthy aging, ambient assisted living, and preventive healthcare. Healthy aging is about supporting people to be active and independent later in life. Ambient assisted living is about enable people to stay longer in their homes of their own choice with the support of technology. In this apartment, we have more than 60 different sensors which are used for detecting different sorts of events and activities. For example, we have sensors in the kitchen that enable us to detect that you are in the kitchen, as well as to detect the interaction between the resident and appliances and furniture. For example, we can detect when you open the fridge or the microwave oven, or when you are about to use some plates or cups in the cupboard. So one of the goals of using smart home technology is to recognize what the individual is doing, if that activity is normal or not. That is really important for enabling preventive healthcare. Considering the objectives of the Remind project, which are about smart reminders for people with dementia, I would like you to consider the following scenario. Old persons visit the doctor and the doctor prescribes a new medication. This medication shall be taken before breakfast. In order to do that, the doctor has to ask the person when the person normally takes breakfast. The doctors might notice the person has difficulties in remembering when to take the medication. So the doctors also suggest a digital reminder. So in order to program this digital reminder, the doctor has to enter the time when the person has to take the medication. So the doctor enters 8 o'clock as the time that the person should take the medication, which means before breakfast. However, this might not be the ideal approach. The resident might be in bed and the device might start beep in the kitchen at 8 o'clock. Or maybe the resident woke up earlier and left the home before the device started to beep. A smart home would enable the doctor not to program a digital device with time, but activities. The doctor would be able to program the device to beep before, during, or after a certain activity. In this particular case, the doctor could program the device to notify the resident before breakfast, and the smart home would have the responsibility for detecting that the user left the bed, perhaps went to the toilet, and perhaps now is in the process of preparing breakfast. So this is the optimal opportunity that is for the system notifying the user about taking a medication. Thus, in the Halmstad Intelligent Home, most of our activities are about recognizing activities and creating models for the resident, or learning the resident routines. In our research, we deal with different technical challenges, such as the integration of technologies, interoperation of technologies, privacy issues, security issues, as well as machine learning and data mining, so we can create the model for the resident, or to make the home more intelligent. In this environment, we also consider non-technical aspects that commonly affect acceptance and adoption of smart home systems in healthcare. Ethics is a very big problem, since some of these systems might take over the ability of the person of doing something. In the case of smart medication reminders, the smart medication reminder should consider that the person might remember when to take medication and should only act if the system believes that the person is about to forget to take medication. Another important non-functional aspect is trustworthiness. So what if there is a power down? The smart home shall have some way to cope with that.
The application of data science and machine learning in medicine is widely anticipated to improve the quality of care and curb unnecessary expenditures by facilitating informed decision support for the care providers. Having said that, the importance of a comprehensive EHR system in itself should not be ignored. Advancements in medical knowledge and guidelines have progressed a paradigm shift in healthcare. Care from a single unit to care across multiple units with varying and specialized expertise. Thus, patient care today, and of course data, is split along a multitude of different care facilities and computer systems, and the integration of this information into a single platform faces numerous challenges, primarily from an organizational perspective. For instance, lack of acceptable and standardized data formats, security and confidentiality concerns, use of proprietary technologies by different vendors, costly interface fees, and many more. As a result, care providers are impeded from accessing complete data sets and thus being unable to understand the complete picture of the patient in the healthcare system. It also results in redundant clinical work and procedures, adding an unnecessary cost on the healthcare system. The County Council Region Halland in Sweden has an electronic health record system called VAS that the providers have been using for several years and into which care providers routinely input clinical data according to region guidelines. Each registered individual in Sweden has a unique personal ID that is being used to link records across different care facilities, allowing seamless exchange of information across different systems. In 2016, Region Halland developed a regional healthcare information platform, which is a structured, filtered, and pseudo-anonymized subset of the healthcare information designed to facilitate clinical and management research. The platform includes information on patients treated since 2009 in different care facilities in Halland. The key strength of this platform is the highly granular coverage of patient and provider level data, both laterally across different care facilities and longitudinally over longer period of times, and the deep integration of cost on visit level. The platform has been carefully designed to operate within the Swedish and EU laws, respecting confidentiality and privacy of individual and corporate data. Access to the data requires an approved project plan by the Ethical Review Board in Sweden. Researchers are also required to sign a confidentiality and secrecy agreement with Region Halland prior to gaining access. For more information, feel free to contact FOU Halland. Thank you.
Medication non-adherence or the failure of patients to take their medication as prescribed is a major public health concern. It is estimated that for every 100 prescriptions, less than 3/4 are filled at the pharmacy, with only 25 to 30% of patients taking their medication as intended by their physician, in terms of timeliness, frequency, and dosage. In light of this problem, it is of no surprise that the World Health Organization in their 2003 report on medication adherence included as one of the take-home messages, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. There's a growing body of evidence showing that non-adherence to medication results in poor treatment outcomes, increased healthcare costs, as well as low quality of life. Adherence is a multidimensional phenomenon determined by interplay of 5 sets of factors. Social and economic factors include, for example, low health literacy, cost of medication. Factors concerning the healthcare system are patient-provider relationship, long wait times, and lack of continuity of care. Condition-related factors include examples such as lack of symptoms, as it is common in patients with hypertension, depression, and psychotic disorders. Therapy-related factors such as treatment complexity, medication side effects, and frequent changes of medications and brands. And last but not least, patient-related factors such as physical or mental impairments, level of motivation and confidence to get better, and perceived risks and susceptibility to disease. Numerous efforts have been undertaken to develop reliable measures of medication adherence. Direct measures include measurement of the drug or its metabolite concentration in body fluids, evaluation of the presence of a biological marker given with the drug, and direct observation of the patient's medication-taking behavior. Even though direct measures are the most accurate, they do not reveal any pattern of non-adherence or their causes. Their intrusive nature can cause anxiety in patients, and results can be misleading due to white coat adherence. EMP devices are adherence monitoring devices incorporated into the packaging of the prescription medication. Common features include recording dosing events and stored records of adherence, audiovisual reminders to signal time of next dose, and feedback on adherence performance. EMP devices are quite accurate. Patients may feel anxiety or stress due to feeling under surveillance, and their bulkiness may lead the patient to transfer medication into another container. Pill counting is an indirect objective measure counting the number of dosage units that have been taken between 2 scheduled appointments or clinic visits. The low cost and simplicity of the method contribute to its popularity. However, limitations include infeasibility in assessing adherence with non-discrete dosages or pro-renatal medication. Additionally, adherence is often underestimated due to the lack of consideration for possible surplus medication, as it is common for patients with chronic illnesses. Clinician assessment and self-report is believed to be the least reliable among all measures. Nevertheless, the low cost, simplicity, and real-time feedback have contributed to their popularity in clinical practice. These subjective measures are able to identify individual patient concerns and subsequently tailor appropriate interventions. The rapid digitalization of healthcare processes results in copious amounts of data available for the analysis of adherence to data-driven approaches. One of these approaches is secondary database analysis, which is cost-effective and now readily available way of measuring medication adherence, the so-called refill adherence. The information for analysis includes the sequences and patterns derived from the data in systems such as electronic prescription service, pharmacy insurance claims, or pharmacy dispensation records. The baseline assumption of refill adherence as a proxy measure is that prescription filling pattern corresponds to the patient medication taking behavior. Evidence supports this assumption, where a reduced hospitalization risk for patients with chronic diseases can be observed as refill adherence increases. Pharmacy insurance claims and pharmacy dispensation data alone draw an incomplete picture of medication adherence, and it is not uncommon for adherence to be under or worse overestimated, leading to inefficient allocation of available resources and worse health outcomes for patients in dire need of intervention. All measures on their own are flawed in some way or another, and a multi-measure approach is recommended, utilizing information from as many sources as required to measure adherence more accurately. Utilizing electronic health records from primary care, specialized care practices, and hospitals allows a more comprehensive view of patient healthcare provider interactions, resource utilization, and patient health development. Changes in treatment plan can be identified in a timely manner, allowing more accurate monitoring of medication adherence, refill patterns, and time of potential drug exposure. The wealth of information contained in EHRs, such as patient demographics, disease histories, vital signs, and lab measurements, can help in identifying individual risk factors for non-adherence and risk groups of patients with higher likelihood of reduced medication adherence. Given that such groups of patients are found, interventions can be tailored towards individuals, addressing their needs and concerns about medication and treatment, helping them with managing their medication regimens, improving health outcomes, increasing quality of life, and reducing healthcare costs. Continuously acquired data through this monitoring, adjustment, and follow-up cycle permits the development of intelligent systems through artificial intelligence, such as machine learning and reinforcement learning. This allows predictive modeling of adherence as well as automated suggestions of personalized interventions with high likelihood of success at time of prescription, giving healthcare providers a chance to address potential issues and concerns early on. An example for such a fully integrated system utilizing EHR is the ongoing project IMETA. IMETA aims to improve medication adherence for hypertensive patients through an AI agent that supports doctors and patients in collaboratively understanding key individual adherence risk factors and designing an appropriate intervention plan. IMETA delivers the selected intervention through a mobile app and follows up on its effectiveness, improving the system over time. This system empowers patients in their pursuit for improved health through self-management and provides healthcare professionals with information they need for patient-centered care. To identify risks and intervention strategies, IMETA uses electronic health records as well as self-report input. The AI agent understands how both medical and personal factors interact with respect to medication adherence and displays this information on a dashboard that guides patient-doctor conversations. The AI monitors effectiveness of interventions in order to improve over time. The IMETA agent is built on many principles of AI, such as meaningful and comprehensive representations of each patient based on information fusion and representation learning, peer group analysis, and interpretable models that predict non-adherence for concrete patients. Finally, intervention strategies that are most appropriate for a particular patient are selected by combining data-driven and knowledge-driven approaches. The combination of patient-centered care and self-management interventions will lead to significantly improved health outcomes and reduced healthcare costs. Thank you very much for listening.
Parkinson's is an increasing neurological disorder in an aging society. According to the Swedish National Register, there are around 20,000 patients who are currently registered in the national database. That constitutes 1% of the residents of Sweden who are over the age of 65. Parkinson's is an incurable disease that is caused by the loss of dopaminergic neurons in the midbrain that results in motor and cognitive dysfunctions, which leads to severe disabilities. Some early symptoms include problems in speech, sleep disorders, depression, constipation, and hyposmia. Motor symptoms such as rigidity, tremor, imbalance, problems in gait and posture arise as the disease progresses that reduces the quality of life of the patients. The cost of care is high, that is on average around $2,500 a year per patient. Around 50% of this cost is due to the unproductivity in the treatment planning. The therapeutic focus is on controlling the symptoms that are alleviated temporarily for a short duration of time using medicines, surgical interventions, and behavioral therapy. Although drug therapy is effective, the long-term application needed for maintenance results in various side effects in reduction of the therapeutic effects. Specifically, in the advanced stages, the patients continue to experience complications within hours or minutes of medication. Because of these long-term effects and the varying intensity and duration of symptoms, the dose needs to be adjusted daily relative to daily physical activities and cognitive behavior of the patient. Hence, the treatment needs to be followed up in regular time intervals for the required dosage levels narrow with the progression of the disease. The increased fluctuation of symptoms results in severe motor and non-motor disabilities, and therefore, continuous monitoring is crucial to determine treatment schemes. The gold standard metric to assess and quantify the severity of Parkinson's symptoms is the Unified Parkinson's Disease Rating Scale, abbreviated as the UPDRS. UPDRS is approved internationally by the Movement Disorder Society as a fact that most complete picture of the PD symptom status could be achieved using the UPDRS. The assessment using UPDRS is divided into 4 parts. Part 1 covers the assessment of mentation, behavior, and mood of the patient. Part 2 covers the activities of daily living, abbreviated as ADL, that is, if the patient is able to perform daily functions without any disabilities or assistance. Part 3 is the motor examination of the patient performed by a neurologist. Part 4 is the assessment of motor complications, also assessed by neurologists. Hence, Part 1 and 2 are self-assessed by the patient. Summing up the scores from each part produces the total UPDRS, representing the global level of impairment severity. The whole assessment takes a couple of hours when assessing the severity in the on and off states of medication. For this reason, the assessments are performed once every 3 to 6 months. Another major disadvantage of using clinical rating scale is the subjectivity of clinical opinion. That is, the clinical scores are the subject's performance on a standard motor test, but also the doctor's interpretation. However, studies prove that a good basis of clinical assessment can be formed by combining computerized estimates and subjective assessment using rating scales such as the UPDRS. Considering the amount of time taken by a clinician to perform UPDRS assessment, subjective bias involved in the assessments, and the chance that a patient behaves differently in a clinic, which is termed as a white collar effect, an automatic, accurate, and continuous transmission of UPDRS estimates of patient from a natural living environment of a smart home could be highly beneficial for a doctor in keeping track of the disease progression in order to optimize rehabilitation and medication of the patient. Current technology enables to analyze biometric information. Home monitoring of motor function is possible in a natural setup at different timings of the day using tools available in the everyday life. The research currently is focused on processing motor symptoms to automate the assessment and to predict the disease status. The current state-of-the-art system for continuous monitoring of Parkinson's disease involve variable sensors, including accelerometers and gyros, to monitor temporal patterns of symptoms. Kinematic data are recorded as series of activities performed by the patients through the transition between off and on states of medication. Quantitative measures of therapeutic responses are computed using features extracted from the signals obtained using the sensors. However, a drawback in such studies was the focus on motor aspects and that the progression of non-motor symptoms that are evident during the ADL, such as cognitive decline, were not evaluated. Previously, one of the state-of-the-art approach to predict cognitive decline in Alzheimer's used motion sensors and movement trackers in smart homes. Such systems could classify dementia and non-dementia with nearly an accuracy of 98%. Such methods could be extended to be employed in the framework to predict non-motor symptoms such as cognitive decline in Parkinson's. We believe that the continuous assessment of motor and non-motor functions through technology during the ADL will provide a real, accurate, and a holistic model of the disease that can improve quality care. Even though many of the UPDRS items, specifically in Part 3 and 4, have been objectively quantified previously, studies suggest that Part 1 and 2, that are on the assessment of mentation and activities of daily living, capture the true impact on the daily functions. Importantly, some studies suggest a stronger correlation between the ADL scores and the disease duration compared to other UPDRS bars, suggesting that these subscores serve as more accurate markers of the disease progression. It is also notable that the self-assessment of mentation ADL by the patient is often unclear to the clinician, since 30% of the patients turn into mild cognitive impairment. This suggests that it is harder for a patient to remember and convey the true information to the clinician. To our knowledge, no complete system exists that allows for automated monitoring of all feasible symptoms that can be determined by the integrated sensor systems in a home environment. The aim is to develop a fully automated system to enable continuous objective home-based assessment of Parkinson's symptoms combined with AI-based context-aware coaching system for optimizing therapy and maintenance. The system couples AI with continuous, unobtrusive sensing of physical and cognitive behavior of the patient living in smart homes to predict symptom fluctuations and disease progression. New and existing methods of sensor fusion, signal processing, control systems, and machine learning algorithms are continually explored, developed, and integrated to our health coaching platform to process the pervasive sensor data stream and evolve the predictive and learning capabilities of the system. Importantly, the proposed system incorporates mechanistic models of behavior control to discover the first principles of cognitive and motoric dynamics associated with disease states. The system's ability to predict a patient's self-sustainability will optimize the healthcare delivery, decrease the overall treatment cost, and increase the accuracy in clinical evaluation. Specifically, with a predictive model of the therapeutic dynamics, the administration of the drug could be controlled. We are using the facilities of Halmstad Intelligent Home, which is equipped with intelligent beds, magnetic sensors that detect opening and closing of doors and drawers, sofas equipped with contact sensors that detect occupancy, motion sensors that detect movement in the home. More data is collected using smartphone sensors, including speech, body movements such as gait, finger tapping on the touch screen. The residents of the smart home are given smart sleepers that have embedded pressure-instilled sensors that transmit foot movement data. Sensor data of the patient residing at the smart home are collected unobtrusively. The data is transmitted to our centralized server at frequent time intervals and used to develop an AI-based predictive models to enable tracking the fine-grained disease progression and on and off fluctuations over time. We are partnered by Regent Halland Hospital in this project where we have access to electronic health records of the patients and the UPDRS scores that are used for the validation of the new methods. Currently, the hospital is treating around 700 patients with Parkinson's disease. This fully automated system would enable continuous at-home monitoring of PD patients combined with AI-based context-aware coaching system for optimizing therapy and maintenance. On one hand, the system will support in fine-tuning the medication to control bradykinesia or hyperkinesia using disease dynamics and pharmacokinetics. On the other hand, it will generate objective estimates of the improvement of motor functions through training. Additionally, intelligent beds will be used to track and improve the sleep quality of the patients. Moreover, data obtained using magnetic sensors on barricades and doors will be used to predict movement patterns indicative of the onset of cognitive decline. A unique feature of this system is that it involves monitoring ADL, speech characteristics, cognitive functions, mood assessment, as well as gross and fine motor functions, thus combining motoric and cognitive behavioral aspects both related to fluctuations in Parkinson's. Importantly, the model will be used to predict the patient's ability to self-sustain over time so that the resource utilization of the hospital treating the patient, as well as local municipalities providing services and support to the patient could be optimized. The proposed system will mitigate the excessive workload on national health systems while decreasing the overall treatment cost and increasing the accuracy in the clinical evaluation of patient status with minimal resource utilization. An outcome will be a system for at-home assessment to get the true PD profile by avoiding the unnatural and biased behaviors and assessment of patient clinical settings. Other outcomes include real-time assessment of just-in-home intervention using patients as their own controls, more sensitive and accurate prediction, earlier detection of symptoms. Finally, a survival analysis method modeling the dynamics of the disease as a function of different parameters to predict the need for further resources and to predict the self-sustainability of the patient. Our team is a multidisciplinary group with researchers, engineers, clinicians who seek to develop this system. The Department of Intelligence System is part of the School of Information Technology, Halmstad University. An important area is the healthcare technology, where the researchers work to create a future where wearable sensors in smart environment are commonplace. The team has vast experience in developing methods related to gait in human movement, speech, cognitive functions, and daily living. Several projects related to detecting deviations in behavior at home has been already carried out within the project group, which will be developed in the PD-specific context. At the Regent Halland Hospital, there is an extensive research unit which serves as one of the project's key elements.
In this video, we have talked a little bit about data that's stored in electronic health records. We've talked a little bit about data acquired with physiological sensors, and we talked a little bit about data that can be acquired in the smart environment. But the very interesting things happen when you put all of that information together, which is still a very big challenge. So if you think of a person with dementia, they might be living at home, but they're also quite advanced in age, so they probably have other health aspects as well. And they might be going in and out of different specialist doctors. So having that electronic health record is very important, even if they are still living at home and receiving home care. So a few big challenges happen then when you start combining all this data. The smart home data is usually continuous data and needs to be pre-processed so that we might be able to raise alarms or just overviews of what's happening in the home up to the doctor in the hospital. Another challenge is how do you visualize and how do you understand what's happening in the home at the hospital when you only have a few minutes to look at those records. So those are some big challenges that we're trying to investigate here at Halmstad University. We have been working very closely with the region and the local hospital to try and understand how we might be able to process and distill all of that home care information in the hospital. So when those patients come into the hospital, that we have a 360 view of their well-being. Now, of course, we haven't figured out this entire system yet, but we have started a 3-year project at the Health Technology Center Halland to investigate all of the technical, legal, ethical issues involved in centralizing or combining electronic healthcare data with home monitoring in smart environments. So we have heard from our researchers a little bit of the research that's ongoing in these 3 different fields of data analysis and signal processing. So if you'd like to know more and know more detail about the work that we're doing, please feel free to contact us. And if you'd like to know more about the project that's currently ongoing at the Health Technology Center Halland, you can also contact us. And we look forward to giving you some updates on this project as we go along. We hope to be releasing some additional videos and demos in the near future. So if you have any ideas related to data analysis, either electronic health records or physiological sensors or smart homes, please get in touch and we'd love to discuss additional collaborations.